we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around that 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working was like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. When we say hyponatremia, the most important thing to look at is the volume status. And the surrogate marker for volume is uric acid. If your uric acid is high, it means dehydration. If uric acid is low, this suggests a fluid overload or a SIADH state. Everybody with hyponatremia should have a low urinary sodium. If the urinary sodium is high, it is suggestive of a sodium loss. And finally, hyponatremia and hyperkalemia suggest a RAS defect in that regards. So all you have to do is to look at volume. If there is hypervolemia, the cause is apparent. If there is euvolemia, this could be SIADH, but think of hypothyroidism and cortisol deficiency. Exclude them before you diagnose SIADH. And finally, hypovolemia with a low urinary sodium is GI and extrarenal loss. More than 25 is a renal loss, where potassium will classify it into hypokalemia in tubulopathy and hyperkalemia in the setting of a RAS defect, which is there from that year-old boy with hyponatremia, and potassium is normal. So, Dr. Sandeep, what are you thinking of?
Sir, we would like to know about the status of hydration, sir. So there was no dehydration. So there is no dehydration. We will look whether it is euvolemic or normovolemic.
So this is a most likely a euvolemic scenario, and there is also hypoglycemia. So there is 2 things which are affected: sodium and glucose, which is ketotic. So you're thinking of a multiple pituitary hormone deficiency. But of course, you have to think of SIADH only after you excluded these scenarios from that perspective. So this is a multiple pituitary hormone deficiency. Next case.
3 weeks old child presented with failure to thrive, and the sodium is 140.
110.
110. Birth weight is 2500 grams, and presently the weight is 2600 grams. Patient is dehydrated, and the PCB is 62. And if you put all this in our interpreter,
clearly we have a dehydrated child who has hyponatremia. Yeah. So what will you look further? So we have a child who is hyponatremic, urinary sodium is high.
Urinary
So this
sodium
is,
high.
look at potassium also becomes important.
So urine sodium is high, so it is definitely a renal defect, sir. So further evaluation will be done based on the potassium level, sir.
So potassium here was high.
High. So it is basically a RAS defect, sir.
So hyponatremia with hyperkalemia, most common cause here would be this. So the most common cause here would be clearly a case of a RAS defect, and most common cause in a boy who doesn't have any DSD would be 21 hydroxylase deficiency. We have a second child, 1-month-old boy with reduced feeding. What we are seeing here, Dr. Sandeep, is that the birth weight has not regained. It's just 100 gram gain in a 1 month period, very less. Hyponatremia with hyperkalemia. So there is a salt wasting. 17 OHP is normal, cortisol is normal, but renin and aldosterone is high. So what are we looking at?
Sir, when the renin and aldosterone is high and 17 HP is normal in a scenario with hyponatremia and hyperkalemia, we should suspect pseudo-hypoaldosteronism.
And the most important thing to look at in pseudo-hypoaldosteronism first will be to go for a genetic etiology or something else.
We should rule out the UTI or obstetric causes.
Yes, so this could be a transient pseudo-hypoaldosteronism. So if you put all the data on the app, what we see, it asks for creatinine. Of course, that becomes important. Creatinine here is normal. Subsequently, if you put the data, it is saying consider impaired aldosterone effect, and you have to think of the other pathway as well from that perspective. And there was a lot of infection and obstruction. So always think of a transient form of PHA before rushing to a diagnosis in that regards. So hyponatremic dehydration requires a lot of correction. There are formulas which are there. We have put out detailed videos on that to look at fluid deficit, how much is the sodium deficit, how much is the isotonic deficit, what's the maintenance, correction, and fluid. So this usually takes approximately 1 hour for me to explain, and often after that people tend to say we don't understand anything. So what we have done is that we have developed a very simple tool which will just guide you as to what is your sodium, what is your weight, will give you how much should be the fluid rate of 3% saline in that perspective. So rather than doing all that, you can simply use this tool which is there as part of our calculators. Now, hypernatremia is rare, but you have to think of DI as a possibility. First, exclude mannitol use, salt load, and diabetes. If urinary osmolality is low, concentrated blood, dilute serum, that is DI. To get a AVP response, positive, this is central, negative, this is nephrogenic DI. If the urinary osmolality is high, concentrated blood, concentrated urine, and the urinary sodium is high, that is sodium load. Urinary sodium is low, that is the extra renal loss or sweating. But mostly, we are talking about chronic hypernatremia is diabetes insipidus in that perspective. So we have this interesting case.
14 days old girl presented with failure to thrive, and the birth weight was 2.6 kg and now presented at 14 days with weight of 2.3 kgs. She was exclusively breastfed and the sodium was 182.
So do you think this weight pattern is good or it's something of concern?
So by this age, the baby should have regained the birth weight, sir. And
so this is a dangerous scenario, and this is something which is 182. Can you guess the gravida of the mother?
She must be primary gravida, sir. And
most common is the primary gravida. And what we do in terms of workup, what we see is that
we need potassium level
normal. Urinary osmolality here is high, 1000. And then
that means urine osmolality is high. That means it must be a high sodium load, sir, in this patient.
So this is a sodium load. Most likely scenario is breast milk related hypernatremia, most commonly seen in primary gravida mother. A lethal disorder which should best be prevented.
Yes.
If you ensure that somebody is not gaining weight, give them extra feed or top feed or whatever to prevent this from happening. So this was a scenario in that regards. 3-month-old girl with altered sodium.
The sodium is 170. The potassium is normal. And
so what will you do from here? Will you do a water deprivation here?
So in this case, already the patient is hypernatremic. So there is no need of a water deprivation test, sir.
So clearly, you look at urinary osmolality, which is
low.
less.
It is low.
So you go for AVP response to classify. So again, that algorithm is running on parallel. It will diagnose this is most likely a DI, and then you can use a AVP test to identify central versus nephrogenic. So we have developed a very simple tool which includes all the electrolytes: hyponatremia, hypernatremia, hypokalemia, based upon just sodium, potassium, and basic inputs. Now again, hypernatremia management is also a challenge. So like for DK, And light for hyponatremia, we have also developed based upon the overall parameters to incorporate all the things to have a gradual loss. How much loss in sodium you want to do in a hypernatremic individual?
In hypernatremic, sir, the correction should be gradual, sir, not more than 9 to 12 in acute cases.
So if it's acute, you can go up to 10 to 12. If it's chronic, 6 will be the upper limit. So you don't want to give too much. General dictum is N by 2, 120 to 130% maintenance. This is what we're looking at. But if you want to have specific guidelines, we have developed a calculator which will tell you how much fluid is to be given per hour to achieve that correction. So this is something which can be used to a precise one. Otherwise, the management is there. Finally, hypokalemia is a common presentation more from pediatric perspective, but not from an endocrine perspective. But if you have hypokalemia with alkalosis, you're dealing with an endocrine excess. So the most important investigation here is the blood gas. Everybody who is hypokalemic should have metabolic alkalosis. If you have metabolic acidosis, then there are only 3 scenarios: RTA, diarrhea, or the use of the drugs which can cause acetazolamide, which can cause diamox, which can cause that scenario. Second thing to look at, of course, is magnesium and blood pressure. So our algorithm is looking at how much is your pH, how much is your magnesium and blood pressure, and classifying based upon that. So just very critical parameters to look at. So exclude diarrhea, diuretic, and malnutrition. Blood gas shows acidosis. Then you differentiate diarrhea from RTA using a urinary anion gap. Urinary anion gap is a marker of urinary acidification. If it's positive, it is RTA. Negative, it is GI loss. If blood gas shows alkalosis, blood pressure is low, we're thinking of Barter, Gitelman, diuretic use. Urinary calcium is high, Barter. Urinary calcium low, Gitelman. If its blood pressure is high, look at aldosterone. Hyperaldosteronism or low is DOC. And then you can classify based upon the response into CAH variants, AME or littles, which are rarer. So hypertension with hypokalemic alkalosis, think of endocrine causes from that perspective.
2-month-old boy presented with failure to thrive, and the potassium is 2.8.
Yeah. So here what you're looking at, of course, the first thing is to look at the acidosis status. There is metabolic acidosis. So now,
since there is metabolic acidosis, now we'll straight away think about the anion gap, sir. And urine.
So urinary anion gap will give you a clue. So what you're seeing here is that urinary anion gap is
positive anion gap, urinary anion gap. So it is mostly RTA, sir.
So RTA could be a possibility. So again, you put the data and you will get it from the interpreter. And if you remember, this is the most important presentation in that perspective. When urinary pH is more than 6, it is distal RTA. Yeah, 3 months.
This is 3-month-old girl presented with failure to thrive, and the potassium is 2.2. Birth weight was 2.8, and presently it is 3.5 kgs.
So not much of a gain. So next issue, of course, will be how much is your blood gas, which shows metabolic alkalosis. So it is showing 7.54. Bicarbonate is also on the higher side. Base excess is high. So this is metabolic alkalosis. The next step is to look at the blood pressure, which is normal. And blood pressure is not there. Look at magnesium. And magnesium here is normal and urinary calcium is high.
So this is a Barter syndrome.
So again, if you go by the algorithm, you go by the interpreter, you will get the likely diagnosis. Next case.
2-year-old boy presented with failure to thrive, and the weight is 8 kg, height 85 centimeter, and the potassium is low, which is 2.4. There is metabolic acidosis with bicarbonate of 38, alkalosis with bicarbonate of 38, and the blood pressure is normal. Urine calcium creatinine ratio is less than 0.2.
So we are dealing with a scenario where you have normotensive, hypokalemic, metabolic alkalosis with normocalciuria. So major step there will be to look at magnesium level. Which will then give you whether it is a malnutrition related. Magnesium is low. So this is a malnutrition related hypomagnesemia.
1-year-old boy presented with failure to thrive. The potassium is 2.4. Yeah. And pH is 7.52, which is metabolic alkalosis with bicarbonate 32. And the BP is, for 1 year, it is high, 120/70. So now BP is high, then...
So we have hypertensive, hypokalemic alkalosis. So now the algorithm doesn't go too much because then it becomes too much. So we have just recommended there that you do a PRA, DOC and aldosterone level, because this is the area where we need to have specialist inputs. So then renin is low, aldo is undetectable. So what do you think here?
Then renin is low.
It is opposite to your case of pseudo-hypoaldosteronism. Where high renin, high LDO, low BP. Here high BP, low renin, low LDO, which means it's a distal defect. So just the diametrically opposite, we discussed about the epithelial sodium chloride channel. This is the increased activity of epithelial sodium chloride channel. So AME versus a possibility of lid. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.